So what should the technologist do when she finds out that she is pregnant? Well, first of all, she needs to inform her supervisor. The supervisor will then provide her with an additional TLD or an electronic personal dosimeter to monitor the equivalent dose to the abdomen and the fetus. In addition, the pregnant personnel or radiographer could wear an apron, a lead apron on a regular basis to shield herself from excess radiation. However, we know that this is not necessary because when you're looking back at the dosimetry reports, you'll notice that the doses received to ourselves as technologists is well below the recommended dose limits, not only for general workers, but for pregnant persons as well. So really, she doesn't need to be wearing an apron around the department, but it's more for peace of mind than anything else. If she chooses to wear a lead apron, she should consider the area that she's working in and the amount of kilovolts that that machine or piece of equipment can produce. Generally, the recommendation for most lead aprons is 0.5 millimeters lead equivalent. Monthly equivalent doses to the embryo and fetus should not exceed 0.5 millisieverts, and this is according to the NCRP in the United States. Now remember, the equivalent dose is the absorbed dose, or the energy absorbed to the abdomen or fetus, multiplied by the type of radiation, or radiation weighting factor. Each type of radiation has a different weighting factor, or a different strength, or a different linear energy transfer based on the type of radiation we're dealing with. And we know that X-ray, the weighting factor is 1. So whatever dose in gray she has received to the abdomen multiplied by 1 will give her an equivalent dose of a certain amount. And the recommendation is 0.5 millisievert, as indicated by the NCRP. Now, if we're looking at the safety code 35, they're not specifically talking about the equivalent dose to the fetus on a monthly basis. Rather, they are talking about the effective dose limit to the entire abdomen for the duration of the pregnancy after it's been declared. The safety code 35 of Canada allows a 4 millisievert effective dose limit, and the NCRP refers to an effective dose limit of 5 millisievert. So you can see there's a difference there. In Canada, they're a little bit more conservative, and they are aiming lower, and they are saying that we will only allow 4, whereas the NCRP is a little more generous, and they are allowing an effective dose of 5. So what should happen to your work schedule after you have declared that you are pregnant? Should it change at all? Should it be altered, or should it remain the same? Now, in accordance with the ALARA guidelines, and this is straight from the textbook, work schedules are designed to distribute the radiation exposure risk evenly amongst everyone working in the radiation field. So if you have declared your pregnancy, should you be reassigned? According to the textbook, no, you should not. You do not necessarily need to be reassigned to a lower radiation exposure risk area, because removing you from that area will mean that the other radiographers are exposed to a higher risk. So what the evidence is suggesting is that after the pregnant radiographer has declared her pregnancy, there is no need, or it's not absolutely necessary, to have her reassigned to a lower radiation exposure position or area of the department. It becomes crucial that she does her best to optimize exposures, to keep doses ALARA, to keep her distance from the source, and to ensure that her readings are read on a regular basis, that's a monthly basis for a pregnant employee, and that the doses do not exceed the limit, which is set at 0.5 millisieverts. Now, there are instances, for the sake of peace of mind, that the pregnant radiographer or technologist will be moved or reassigned to an area of lower exposure. Even in such instances where she may be reassigned to ultrasound, taking patients in and out of the room and preparing them for the procedure, or maybe she's reassigned to reception or that kind of thing. Even in those instances, her monthly dose will be monitored, and she will be given an effective dose limit of the 4 or 5 millisievert according to policy and regulation within the facility. Regardless of whether the technologist is pregnant, the actions of time, distance, and shielding should be applied. the amount of radiation received is directly proportional to the length of time spent with the ionizing radiation. So as the time increases, the dose that you receive as a technologist will increase as well. The most effective means of protecting yourself from ionizing radiation is to keep your distance, is to stand further away from the source, because this will reduce your dose substantially. Let's look at the inverse square law as an example. Doubling the distance between your body and the radiation source will divide the exposure by a factor of 4. This basically means that the intensity at the new distance is only 1/4 or a quarter of the original intensity. Please do go ahead and study the formula for the inverse square law calculation. You will be expected to know this for the final exam. Here is a good example that can be found in the textbook. It shows you how the calculation is done, and it indicates here that if you stood at 1 meter away from the X-ray tube, initially the exposure would be 2 milligray per hour, and then you move back and relocate yourself to 2 meters from the X-ray tube. What would your exposure be? And it shows you a breakdown of how that is calculated. At the end, it would be a quarter of 2 milligray, which is 0.5 milligray per hour. So we have discussed time and distance, but how about shielding? Now, shielding is not only something that we wear in terms of personal protective equipment, but shielding is also in the structure and the design of the facility and the room you are working in. For example, the walls surrounding the X-ray machine is designed in such a manner that it includes lead within the walls, as well as a thick concrete layer so that the X-rays cannot penetrate through. The walls and the doors and the ceilings within the room is either considered a primary or a secondary protective barrier. So a primary barrier protects against the direct radiation or unscattered radiation when the X-ray tube source goes from the X-ray tube itself to the patient and then goes directly to the wall behind it or the wall bucky. That is considered a primary protective barrier, whereas a secondary barrier protects against the scatter radiation coming from the tube and the patient, or leakage radiation from the tube shielding. So these are things like the lead-lined glass window that we're looking through, or it could be the ceiling or the floor in the X-ray room. Those are considered secondary protective barriers. Any barrier that is not hit directly by the primary X-ray beam is classified as secondary. For the most part, we are protecting ourselves from secondary radiation when we are wearing lead protective clothing. Lead aprons should be chosen based on the amount of kilovolts you'll be working with, or the type of X-ray room you'll be working in, whether it's fluoro or angio, or whether it's the operating room, or whether it's just a general X-ray room that's only doing extremity work, where the radiation levels are quite low. Although commonly the full lead apron found in most facilities are of a 0.5 millimeter thickness. Some facilities that are only doing, let's say, hands and feet and knees, they don't really need a lead apron of 0.5 millimeters. They can get away with just 0.25 millimeters lead equivalency. So it is always, a good thing to be checking those lead aprons just to make sure that you are picking the right one, that you have what you need to protect yourself if you were engaging in an exposure in a room like an angio or fluoro procedure. Personal protective clothing must provide adequate protection without being unduly restrictive and heavy. If you remember from the image recording course, these lead protective devices must be checked at least once a year to ensure its integrity, so to ensure that there is no cracks within the lead and that it is still adequate for use. If the X-ray equipment operates up to 100 kV, you should have aprons available that are 0.5 millimeters lead. Heavy leaded gloves usually have a limit of about 0.25 lead equivalency, and this is because it's very difficult to use these gloves if it's too heavy. So it's pointless in having something more than 0.25 millimeters of lead because it wouldn't be used anyway. Aprons may be of the style which is open at the back, and this reduces extra weight and extra cost. But the assumption is that when this type of apron is worn, that the technologist or radiologist is always facing the radiation source. Lead glasses, when used and when available, should be a minimum of 0.35 millimeter lead equivalency to protect the eyes and to reduce the potential of cataracts forming in the future. Secondary protective barriers, such as the control booth, should be at least 7 feet upward from the floor, which is around about 2 meters in length. It should be secure and it should be permanent when it's in an X-ray room. The window should be a minimum of 1.5 millimeter lead equivalency, and the exposure cord should be short enough to prevent the radiographer or technologist from leaving the control booth and getting exposed accidentally. As is stated in the Safety Code 35, a general rule is that the X-ray technologist should always be controlling the exposures from the control panel area, and this area should be adequately shielded. The operator should remain in this area except in cases or special circumstances where the technologist needs to be by the patient's side during a procedure, let's say fluoroscopy, and in this instance, protective clothing has to be worn. If you are not by the patient's side, you must have a clear view of the patient during every X-ray examination, and you must be able to communicate with the patient and or attend to the patient's needs when necessary. Mobile units should be used only if the condition of the patient is such as to make it inadvisable for the exam to be carried out with a stationary unit in the main X-ray department. If you are taking a mobile X-ray, make sure that the beam is directed at the patient and that you stand at 90 degrees to the direct beam. Avoid holding the patient if possible, and especially avoid holding the image receptor and putting yourself in harm's way. If you're taking an exposure, the cord should at least be a distance of 2 to 3 meters in length away from the source. Avoid any repeats, wear lead protective aprons, and increase your distance. According to the Safety Code 35, the operator must not stand in the direction of the direct beam and must be at least 3 meters from the X-ray tube unless wearing personal protective equipment or standing behind a leaded shield. When you're using a C-arm, you must wear a lead protective apron. Positioning of the C-arm is important, and where you stand in relation to the patient is important as well to minimize your dose. So where should you stand? When the C-arm is in an AP position, the X-ray tube should be underneath the patient and the image intensifier should be above the patient. Bringing the image intensifier closer to the patient reduces the scatter radiation to yourself. Of course, you have to maintain your distance when it comes to using C-arm fluoroscopy. When the C-arm is in a lateral position, you will be standing on the side of the image intensifier. You will be standing facing the X-ray tube. And why do I tell you to do this? And that is because the exposure rate caused by scatter radiation near the surface or the entrance surface of the patient exceeds the exposure rate, which is caused by scatter near the exit surface of the patient. So in this instance, it makes more sense to be facing the X-ray tube, to be on the side of the patient that does not have direct exposure to the beam, because there'll be less scatter on that side of the patient, and that means less radiation to yourself. So how about fluoroscopy? When you're working in this area, you should have a lead apron with a minimum of 0.5 millimeter lead equivalency. You should be using a thyroid shield. You should be using gloves if they're available, but they are heavy and cumbersome and are mostly used by the doctor and not yourself as the technologist. If you have lead glasses available that are 0.35 millimeters thickness, wear them. When using a half-back apron, that means the backside of the apron is completely open, make sure that you do not turn your back towards the X-ray beam. Make sure you're always facing the X-ray beam. Try to use short fluoro times. Try to use under-table fluoro. Most of the time it's fixed, so the X-ray tube is under the table to begin with. There should be a protective lead curtain, which is at least 0.25 millimeters of lead, and this is placed between yourself and the patient, but it's not a substitute for personal protective equipment such as an apron. And lastly, every attempt should be made to try and keep the dose and the time as low as possible.